Okay, so my presentation is on ototoxicity. I'll be talking about anti-neoplastic agents, aminoglycosides, and anti-malarial drugs. So what is ototoxicity? Ototoxicity is when there's damage to the hearing and/or balance organs after exposure to medications or chemicals that affect the inner ear. The etiology of all of the agents that I'll be talking about are taking classes of drugs that have been identified as ototoxic, affecting the inner ear. So some common ototoxic medications are aspirin, quinine, loop diuretics, such as Lasix, aminoglycoside antibiotics such as gentamicin, neomycin, streptomycin, and amikacin, chemotherapy such as cisplatin and carboplatin, and anti-malarial drugs. The most common agent I have seen in the clinic is cisplatin, which is a type of chemotherapy. And I think the most research that is being done on ototoxic medication is also cisplatin because it is so common. Then there's also environmental chemicals that can be ototoxic, such as mercury, lead, and carbon monoxide. So some common characteristics of ototoxicity are history of taking ototoxic medications, progressive high-frequency sensorineural hearing loss, tinnitus, which can occur but not always, and vestibular symptoms, which can also occur but it doesn't always occur. The overall epidemiology, it varies widely and it ranges from about 2% to 25% for those who develop hearing problems and 1 to 10% who develop vestibular function. So it's seen much more for people to have hearing loss rather than vestibular function. And now we'll be talking about some antineoplastic agents. And antineoplastic agents are used to act or prevent or inhibit the development of neoplasm, and a neoplasm is a tumor. Some examples can be oxaliplatin, which treats metastatic colon cancer. And drugs include anti-cancer, chemotherapy, cytotoxic meds, and hazardous drugs. Some platinum-based chemotherapy includes cisplatin and carboplatin. Cisplatin treats lung, head, neck, and ovarian cancer, and carboplatin treats testicular cancer, ovarian, head, neck, cervical cancer, bladder, brain, and some lung cancers. The epidemiology occurs in all age groups. The incidence is unknown due to varied criteria to define ototoxicity. Unfortunately, there's not really a standard for defining what is ototoxic or when a hearing loss reaches a certain severity. There are things through ASHA where they consider some guidelines or what are considered ototoxic, but because criteria varies between practices, it's hard to really get a clear indication of the epidemiology. And because of the wide range of reaction to drugs in different ethnic groups, the protocol for monitoring ototoxicity, and the lack of referrals for otologic symptoms. A lot of the times we run into the problem where our patients do not tell either their physician or their oncologist about their hearing loss until it's progressed enough to affect their quality of life, and we might miss the ototoxic effects. So it's really important for us to be monitoring these patients and their hearing. The incidence severity is seen to be dose dependent, and factors such as age, gender, comorbid conditions also play a significant role. The pathogenesis, the drugs will destroy DNA structure and function and interfere with transcription and blocking RNA synthesis affecting protein synthesis. So who is at risk? Pharmacists who may be exposed to these drugs, nurses who prepare or administer the drugs, and any doctor who comes into contact with patients who are taking these drugs. And of course, the patients taking the drugs themselves. I think what's really important is to just remember that it's not always just the patient taking the drugs. I guess I never really thought about people that are coming in contact with these drugs who are not ingesting them to be at risk. So I thought that was definitely something to keep in mind. The clinical presentation is bilateral progressive high frequency sensorineural hearing loss. It can occur with tinnitus, or tinnitus can just occur without hearing loss. So we need to keep that in mind as well, that could definitely be a starting symptom of ototoxicity. And they can also have vestibular symptoms as well. So this is just showing the hearing loss progression in ototoxicity. As you can see, it started out in one ear in picture B and then progressed to both ears. With ototoxicity, you'll always see the hearing loss go down in both ears. It won't really just affect one, but in this case, it just started out in one ear, but ended in both. And you can see by picture D, it starts affecting those speech frequencies pretty heavily in those mid frequencies. So this is the Brock ototoxicity grading scale. According to Brock, for bilateral hearing loss, a grade 0 is considered less than 40 decibels at all frequencies. Greater than 40 decibels at 8 kilohertz only is considered a grade 1. Greater than 40 decibels at 4 kilohertz and above is considered a grade 2. Greater than 40 decibels at 2 kilohertz and above is a grade 3, and greater than or equal to 40 dB at 1 kilohertz and above is considered a grade 4. So this is important when we're writing our reports. We could be using this terminology for physicians to know how severe the ototoxicity is, and I think it just makes us sound professional, and just using the right terminology can be super helpful when talking to other medical practitioners. Then there's also the Chang ototoxicity grading scale. You'll see this one being used more with children. It's a little bit more specific, and they use more subcategories. So Chang's grading scale goes from a 0 to 4, and their 0 is considered less than or equal to 20 dB at 1, 2, and 4 kilohertz. So their grade 0 is considered with the normal limit still. 1A is greater than or equal to 40 dB at any frequency, 6 to 12 kilohertz. 1B is greater than 20 and less than 40 dB at 4 kilohertz. 2A is greater than or equal to 40 dB at 4 kilohertz and above. And 2B is greater than 20 and less than 40 dB at any frequency below 4 kilohertz. Grade 3 is greater than or equal to 40 dB at 2 or 3 kilohertz and above. And grade 4 is greater than or equal to 40 dB at 1 kilohertz and above. So you can see that there are a little bit of differences between the two. Whereas a grade 0 for Brock, they could have a mild hearing loss, and a grade 0 for Chang does not. And I think what was important about Chang's graph here is with normal tympanogram. So we should always be making sure that their middle ear function is within normal limits. So diagnosing ototoxic effects is really based on case history and medication lists and the audiologic test results. And like I was talking about before with ASHA having their guidelines, so a loss of 20 dB at a single frequency, losses at 10 dB or more at 2 adjacent frequencies, And a loss of response at 3 consecutive frequencies compared to baseline is considered ototoxicity according to ASHA. So audiometric monitoring, there's currently no perfect ototoxic monitoring protocol, but it is recommended that all patients exposed to ototoxic drugs monitor hearing regularly during treatment and even post-treatment. When signs of ototoxicity are first detected, changes to patients' treatment may be warranted. So because there's no perfect ototoxic monitoring protocol, that doesn't mean that there isn't a protocol in place. There's just no standardization to it. So ASHA does have a flow chart right here for ototoxic monitoring protocol for patients with cancer. So on the left-hand side, you can see chemotherapy with platinum derivatives. The baseline assessment includes case history, otoscopy, tympanometry, audiometry, DPOAEs, click and tone burst ABR and ASSR as indicated. So that's not something we do right away. And then patient counseling. And then you go down, and cisplatin chemotherapy, we monitor following every cycle of chemo. And for carboplatin, we monitor following every 2 to 4 cycles of chemotherapy. So it is a little different between the two. And if the patient has additional ototoxic treatments, we continue the ototoxic monitoring protocol depending on what drug they're taking. And if they're not, then we move to the post-chemotherapy treatment follow-up plan, which is you should be scheduling them for an audio at 3 months, 6 months, 9 months, and 12 months. And after that 12-month mark, they should be seen on an annual basis. When you go to the right-hand side, the cranial radiation therapy, the baseline assessment is the same. Post-radiation treatment assessment, depending on their high risk or low risk. If they're high risk, they should be followed every 6 months for 5 years. And if they're low risk, they should be followed annually for 5 years. But for both groups, annually for 5 additional years, totaling for 10 years of follow-up post-diagnosis. So that's a long time. They should be getting an annual at that point every year. So some medical management, a baseline audio before treatment begins is super important. We do not want to misdiagnose ototoxicity. And if they already have hearing loss prior to their treatment, we want to know about it so that we have accurate baseline or accurate threshold shifts. Then we should be following each cycle of treatment, and we should be talking to the team members, including the oncologist and pathologist, about possible adjustments of medication if hearing starts to be affected. So the audiologic treatment includes hearing aids. Once hearing is compromised in the speech frequencies, hearing aids can be effective for those who have lost their hearing to ototoxic medication. The major problem with trying to manage ototoxic medication is usually these medications are treating a much more life-threatening problem, such as cancers, tuberculosis, where you have to weigh the pros and cons and how much these drugs are helping your primary condition to the side effects of a now secondary hearing loss. So it's out of our scope of practice to tell somebody to stop taking their medication, but if this is affecting our patients' quality of life, it's their responsibility to start talking to their physicians and their oncologists about how it is affecting their life, but also we can be interacting with those healthcare professionals as well and trying to come up with a plan together. Some considerations for hearing aid programming. Hearing aids with frequency lowering technology by linear frequency transposition, nonlinear frequency compression, frequency translation, also known as audibility extender, sound recover, and spectral IQ. This will help with limitation of functional bandwidth of the ear. So I have tried frequency transposition, and it definitely sounds different. It almost gives it like a shh sound, which makes sense because you're shifting, or you're basically taking the high frequencies that they don't hear and just shifting them to lower frequencies that they still have hearing in. So it's going to sound weird at first, and we should let our patients know that. But we should definitely consider this when programming for these patients. And like I've been saying, early detection is key. So testing ultra-high frequencies up to 12,000 hertz by pure tone audiometry, or performing otoacoustic emissions with extended frequency bandwidth. OAEs are recommended because it is more sensitive to detecting auditory dysfunction during treatment. So what this is telling me is if you have a choice between testing the ultra-high frequencies with high-frequency headphones and OAEs, especially with children who are taking ototoxic medications, go for the OAEs. They're going to give you more information, and they're going to be a little bit more sensitive. So now I'll be talking about my case study. So the case study is about a 39-year-old male diagnosed with testicular cancer, and he had a successful surgery to remove the cancer. He's receiving 3 rounds of cisplatin over 3 months in conjunction with gentamicin. Within 24 hours of receiving his first dose, he reported bilateral tinnitus, with the right being worse than the left. His tinnitus began to decrease in severity after that 24-hour period, but it was definitely still noticeable. So this is one of those cases where tinnitus was the main symptom rather than hearing loss, and we should just be aware that maybe the hearing loss is slowly creeping up on us. So testing, otoscopy, pure tone audiometry, including high-frequency audiometry, tympanometry, acoustic reflex thresholds, and decay. So this is his baseline audio. And as you can see, they tested the ultra-high frequencies, and he had no response at 16 kilohertz. And he was already at a moderate hearing loss at 14 kilohertz. But again, we don't really utilize that high of frequencies in our everyday life, so it's not affecting his day-to-day living. And then he had normal hearing from 11 kilohertz and up. So some further testing that was done. He never got tested prior to his second dose, but reported that his tinnitus increased in severity after second dose with no sense in changes of hearing. So again, that tinnitus is the real problem with this patient rather than the hearing at this point. And another audio was completed 24 hours prior to his third round of cisplatin. So his next audio, you can see that in the first column is frequency, second column is his dBHL, and his third column tells you the change in decibel. So as you can see, going from bottom to top from those ultra high frequencies, still no response in those really, really high frequencies at 16 kilohertz. But you can see it slowly creeping up into those lower frequencies and speech spectrum frequencies at like 8 kilohertz. He's starting to have a 20 decibel shift, and he's even having a little bit of a shift in those mid frequencies in the right ear. He had a 5 decibel decrease at 3000 hertz. So there's definitely some changes happening. So the patient started having some concerns. He began to increase in his worry about continuing the cisplatin treatment because he did not want to experience even worse tinnitus. He was counseled that it is likely that his hearing may also decline as time goes on because of the treatment. And the patient ended up deciding not to receive any more chemotherapy because he was so worried about the loudness of his tinnitus growing. And ultimately, it is up to the patient. So some next steps, talk to the team members about the patient's decision and how it will affect his underlying diagnosis. Counsel the patient about weighing pros and cons of stopping chemotherapy and hearing rehabilitation. And refer for a tinnitus evaluation, especially because it seems to be bothering him so much. A tinnitus eval and maybe recommending some tinnitus programs such as cognitive behavioral therapy would be really beneficial for this type of patient. Follow-up testing, we should continue to have regular audiologic evaluations for at least 6 months post-stopping chemotherapy. After, we should have an annual audiologic evaluation. If hearing begins to decrease, more counseling on oral rehabilitation should be warranted. And again, tinnitus management options such as the CBT. Another thing that I was thinking about that they didn't do, but I think it would have been beneficial, is the tinnitus handicap inventory. It gives us a subjective measure on how it's affecting his daily life, and we can track if he starts therapy, how it will change the tinnitus handicap score. So I was just some thoughts and to keep in mind when you're treating these types of patients. Now we'll talk about aminoglycosides. So what are aminoglycosides and what do they treat? They're used for aerobic gram-negative bacterial infections such as septicemia, respiratory infections, urinary infections, gastrointestinal problems, neonatal sepsis, and second-line tuberculosis therapy. So aminoglycosides include streptomycin. Predominantly, this is vestibular toxic rather than cochlear toxic. Gentamicin is also more vestibular toxic. Amikacin, neomycin, kanamycin, capreomycin are all considered cochlear toxic. So the pathogenesis, these are the proposed mechanisms. Again, we don't necessarily know exactly how it enters the inner ear, but these are some really good possible entryways. And they include the entry into the scala media via Reisner's membrane, and that's through and between the marginal cells. Through the stria vascularis, again, also through and between the marginal cells, and the basilar membrane. At the hair cell level, potentially they enter via the mechanotransducer channels located on the sterocilia of the hair cells. So this picture shows the cell death by aminoglycosides, and I'm just going to explain a little bit of what happens. So with aminoglycosides, they can penetrate cochlear and vestibular hair cells by mechanotransduction channels and reaching higher concentration than in other cells of the organism. And once it is within the hair cells, they act by several molecular mechanisms leading to oxidative stress, exotoxicity, protein synthesis inhibition, and mitochondrial dysfunction with apoptosis. So cochlear ototoxicity begins in the basal turn and damages the external hair cells first. And they say this is a very similar way that hair cells are damaged with acoustic trauma and presbycusis. And they present themselves clinically similarly. And these are words by O'Sullivan et al. These are not my words. I couldn't have explained it better. So the epidemiology. So the incidence becomes higher who receive multiple courses of intravenous aminoglycoside antibiotics, and they could be greater than 50%, which is pretty high. But This number varies due to patient population, comorbid conditions, previous aminoglycoside treatments, and types of aminoglycosides, and again, dosage and duration. It should also be noted that this can treat tuberculosis and cystic fibrosis patients. There is an interesting finding that close to 100% of patients with the 1555A gene mutation are reported to develop hearing loss following aminoglycoside exposure. What this tells me is that if we're looking at somebody's chart and they've had genetic testing and they're taking ototoxic drugs, this would be something to just be aware of so that we can better counsel our patients about what's to come. So the clinical presentation is a high-frequency sensorineural hearing loss and tinnitus. And it begins at the ultra-high frequencies and can be detected through high-frequency audiometry, but with continued exposure, damage can lead to those lower frequencies. So some risk factors. Higher risk occurs when persons are receiving concurrent ototoxic drugs, if the person has insufficient kidney function, their age, their genetic vulnerability, the higher the dose of the drug, repeated exposure to aminoglycosides, it leads to additive damage to hair cells and other structures, and subsequently to deafness. So if someone was taking aminoglycosides for not their current disorder, but a different disorder prior, we should really know about it as well because that'll put them at a higher risk. The mutations in the mitochondrial 12S ribosomal rRNA makes patients highly susceptible to aminoglycoside ototoxicity as well. So some audiologic treatment are hearing aids. Once hearing is compromised in those speech frequencies, hearing aids can be effective for those who have lost their hearing to ototoxic medications. And again, the major problem with this is just these medications are just treating such a bigger problem that the hearing is secondary. But if we're able to help these patients' quality of life, we should with hearing aids. And with the research that I've done, hearing aids have worked pretty well for these patients because of the high frequency hearing loss that they have. Yeah. So some considerations for hearing aid programming: hearing aids with frequency lowering technology by linear frequency transposition, nonlinear frequency compression, frequency translation, and again, what they're also known as in the softwares, and this will help the limitation of functional bandwidth of the ear. So medical management includes audiometric monitoring throughout treatment and after treatment is stopped. It has been seen that even 6 months post-ototoxic effects can occur. So it is very important to keep regular audiologic evaluations. Even if you don't see any hearing loss throughout the treatment, that doesn't mean that these patients aren't going to have ototoxicity. And it could very well happen post-discontinuation of the medication. So when changes are detected, possible alternative treatments are to be discussed. Monitor changes in hearing even if treatment cannot be altered due to the underlying condition. And we should be just assisting patients in maintaining communication by giving them communication strategies, amplification, counseling, and possibly assistive listening devices. I think the first and foremost, the most important thing is the communication strategies, especially if the person does not want to pursue amplification, whether that's for vanity reasons, budget-wise, whatever. Giving them better communication with their peers is so important. so that they can utilize this. So some articles I've been reading give us a little insight on the research that they're doing to prevent ototoxicity. And gentamicin Texas Red, also known as GGRT, is a useful tool in tracking aminoglycoside transport to the cochlea. So studies showed when GTTR was administered, it was first found in stria capillaris before the marginal cells in stria vascularis and endolymph. So the more information we have on being able to trace these medications through the body and how it gets in the ear will lead us to a solution eventually, or hopefully. And just the more information we have, the better. And because of the commonality in genes expressed between the two tissues, it is hypothesized that agents that trigger a pathological change in one may similarly affect the other. So closure of vitamin D transporters of the stria vascularis as entry has not fully been researched, but it is hypothesized that it could serve as a mechanism to prevent aminoglycoside ototoxicity. So both the stria vascularis and kidneys contain high levels of megalin, a vitamin D transporter, which may play a role in the transport of aminoglycosides into the endolymph and closure of manipulation of vitamin D transporters. So a couple of more prevention theories. So blocking MET channels and that includes amiloride, quinine, or curare, preventing aminoglycoside entry into the hair cells and protecting hair cells from its effects. So the problem with this prevention is many blockers are toxic to humans and not suitable for therapeutic agents. So we cannot be hurting patients while we're studying prevention. So research has been tough with this theory. Lastly, we're going to talk about anti-malarial drugs. So some types of anti-malarial drugs include quinine, chloroquine, hydrochloroquine, primaquine, quinidine, and pyrimethamine. So the most information I was finding on pathogenesis of anti-malarial drugs was on quinine. And quinine, this blocks cilia channels, which would normally control outer hair cell motility. As a result, it's causing the hearing loss. It is thought that the mechanism is similar to salicylism, and salicylism is a toxic condition that occurs due to excessive intake of salicylic acid, which symptoms of ringing in the ear, nausea, and vomiting. So something I thought of while reading this was that I know salicylic acid is in a lot of face washes. So I wonder if you put too much face wash on, you can get salicylism. But just a little fun fact. And the epidemiology, it varies widely, especially because malaria is mostly treated in other countries. The most place I was seeing this drug being studied was Portugal, but it's really rarely seen in the States. It should also be noted that anti-malarial drugs not only treat malaria, but it also treats rheumatoid arthritis and lupus as well. So that's very interesting, and we should keep that in mind. Some risk factors include age, concurrent ototoxic medications, and genetic vulnerability. The clinical and differential diagnosis. So it affects both hearing and balance, and it's typically bilateral sensorineural mild to moderate hearing loss. It should be noted that malaria itself could cause the hearing loss. So not only is the ototoxic medication causing the hearing loss, but malaria is as well. If the anti-malarial drugs is treating malaria, that should be considered. Usually, the hearing is restored after discontinuation of the drug, so that is good. This is the only drug out of the three which is considered reversible. And I put usually in bold with aspirations because in a study that I read about, 100% of the patients did see their hearing go back to normal after stopping the drug. But again, there's always going to be those atypical cases where their hearing isn't reversible, and I haven't read enough about anti-malarial drugs to know that 100% of the time it does reverse. So usually, or most of the time, I would say, for anti-malarial drugs in this case. And it is dose dependent and duration dependent. So after the drug has been discontinued, hearing thresholds are seen to get better or return back to baseline, unlike the other two types of ototoxic agents. So when we're differentially diagnosing, that is the main difference between the three drugs or between the two and the one. Antineoplastic agents and aminoglycosides have much more in common to each other than anti-malarial drugs do. The audiologic treatment, you want to wait and see if the hearing loss is reversible before recommending hearing aids, of course. But again, most of the time it is reversible. So this is something that when we're counseling these types of patients, we can give them good news, or we can tell them that we have seen in research that most of the time hearing does return back to normal. And then, again, ototoxic monitoring is really good as well. So some differential diagnosis between drugs, taking a good case history. I cannot stress being a good case history taker in the case of ototoxicity. Knowing what drugs the person is taking and asking follow-up questions about start, duration, and frequency of the drug use is extremely, extremely important. Keeping in contact with other physicians and the drug's effects and the duration of use and frequency is also important. I recently just had a patient come in who was getting her baseline audio, and I made sure to know exactly when she was getting her next round of treatment, how long she was having it for, what was the dosage. It's really important to ask those follow-up questions and probe the patient about it, because this is information that can help us when we're monitoring. So really taking a good case history is key. So I was trying to think of some other disorders that you can confuse this with, and presbycusis or acoustic trauma can be very similar in clinical presentation, but this is why it is so important to take a good case history and always ask about medication use when getting the history down. Because if someone has a high-frequency sensory neural hearing loss but isn't taking ototoxic medication, it's not ototoxicity. But if they do have the high-frequency hearing loss and they are taking the medication, then it could be a little bit of both. If they're an older patient, they could both have presbycusis and ototoxicity, but that's why it's super important to take a baseline audio. And these are my references, and thank you for listening.